Good morning. It's 8 o'clock and I want to thank you all for joining us this morning. It is a snowy day here in Toronto and I hope it's warmer and potentially sunny wherever it is you're joining us from across the province. I would like to start this by introducing myself. My name's Jackie Roddy and I am the Partnership Development Manager for 211 Ontario. And this webinar is looking at how 211 might be able to work more closely with your Ontario health teams to serve all Ontarians, and in particular, the more vulnerable in Ontario. Before we start though, a few housekeeping items. This audio goes just one way. You can hear the presenters, but we can't hear you. I do encourage you to use the chat function, which if you hover on the lower part of your computer screen, you should see a chat icon. You can type in there. When that icon glows orange, it means that somebody else is also typing or is sending a note to all attendees. You have control of your volume, so however your computer best works for you to increase your volume if necessary. And we have asked our panelists to speak clearly and to use their microphone however best it is for their particular system. We're also recording this webinar and we'll be sending it to all registrants and to others who couldn't attend but have asked for the recording. We have a few presenters with us today. Outside of 211, we have Dr. Kim McIntosh from the Collingwood, Georgian Bay area. We also have Michael Cole and Parissa Mafar here with us in the Toronto office. And I'd like to thank you all for joining us and welcome you here this morning. I'd now like to turn it over to Karen Milligan from 211 Ontario Services to give her greetings and say hello. Good morning, Karen.
Good morning, Jackie. Can you hear me?
Yeah, we can hear you fine, thanks.
Excellent. Well, thank you to everybody for joining us this morning. And if I recall correctly, we were just up past 90, excuse me, registrants for today's session. So we really appreciate people making time to participate. And in particular, as Jackie said, we thank our guest speakers today. I also just want to give a special shout out. We have quite a large number of registrants, and by far the most registrants came from the Peterborough area. So I just wanted to say hello to everybody out in Peterborough. We also have people from across the province, and again, just acknowledging that we know that everybody has very busy schedules, so we appreciate you taking time. I also just want to thank Jackie for her leadership in pulling together this webinar and for herding cats, as we like to say, and balancing everybody's schedules and presentations into one. And I also want to thank Solomon, who helped us put together the package that we'll walk through today. Fiona, Carrie, Angela for their contributions in putting together today, and to Krista Hanstra from Change Foundation, who provided some strategic advice around the content and presentation this morning. So thank you to everybody who has played a role and been involved. And Jackie, I'll hand it back to you.
Thanks, Karen. And I'd like to clarify, Dr. Kim McIntosh is from the Aurelia Couchiching OHT. My apologies, Dr. McIntosh. I did have that written down. I sadly wasn't following my notes. I'd like to start this PowerPoint by actually showing you a video put together by Dr. Block. So I'm going to play that video for you now. It's just a 1-minute quick snapshot of 211 working with the health services.
What if we had a tool at our fingertips to help find free or low-cost meals, food banks, home-delivered meals, breakfast programs, or donated baby food for people? Or if someone is experiencing financial challenges, having a way to search for emergency or government assistance, tax clinics, eviction prevention programs, help filling out forms, or agencies providing help in lieu of money, like home maintenance help. We do. Just call 211.
The database can also be searched online, and a health provider can print a list of resources to help a patient.
Call 211 today and spend a few minutes talking to our team, or go online at 211.ca to find your local 211 service and learn more about how 211 expands the circle of care for your patients.
The 211 system is comprised of 6 regional service providers, numerous data partners, and Ontario 211 Services, who basically the commissioner for the system. Ontario 211 Services works in collaboration with the regional service providers, who we will often refer to as being the contact centers throughout this presentation, and data partners. Ontario 211 Services provides strategic direction oversight to the system and distributes funds received from all 3 levels of government, in particular the Ontario Ministry of Children, Community and Social Services. Funding is also provided by the United Ways, and project dollars have been provided by various foundations over the years, including Green Shields and Trillium. The 6 regional service providers are referred to as contact centers and located in Thunder Bay, Ontario, Collingwood, Windsor, St. Catharines, Toronto, and Ottawa, with Ottawa being the bilingual center and Toronto providing overnight and weekend services. Collectively, these 6 centers serve the entire province 24 hours a day, 7 days a week, 365 days a year. The 6 contact centers are integrated into the provision of, so that they can deliver 211 core services. And these core services we have brought being 3 general areas: our inquiry service, resource database, and reporting. The inquiry service, this flow diagram sort of illustrates how the inquiry service works. A call comes in, there is a non-clinical needs assessment, there's a provision of information and assistance, a referral made to a community service, advocacy and follow-up are offered, and then there's documenting of the call so that we can aggregate the data for the needs and the area where the person was calling from. 211's inquiry service has multiple channels of access: phone, chat, text, email, and the online search portal. All inquiries provided by 211 are delivered by those 6 regional service partners, all of whom are accredited by the Alliance of Information and Referral Systems. The accreditation standards define the information and referral process, which we might at times refer to as the I&R, so that's information and referral. The accreditation standards also establish criteria for the database. They mandate support for community planning activities, which is what we do with the aggregated data that we collect. They incorporate a broad view of collaboration, include provision for the socially responsible use of technology, and describe the role of information referral services in times of disaster. 211 has been called on during many of the natural disasters throughout the United States. If you think to the hurricanes and to Sandy, 211 was called upon to provide general information to the public at large. All inquiries are confidential and answered by community navigation specialists. The community navigation specialists are certified by the Alliance, also certified by the Alliance, and the certification requires that they have a combination of education and work experience. They then must write an exam, and that allows them to be certified for 2 years. Once they're certified, they then must recertify every 2 years through professional development and submit that for recertification. The specialists will answer the call, complete a non-clinical needs assessment with the caller, which is usually done in a conversation style. So most calls or chats are not addressed in what we would refer to as a decision tree. It's more of a conversation where there's rapport established, we get to the crux of the need of the individual, and then we go from there. Information referral provided, advocacy is offered only when it's warranted and when it's wanted. We are a confidential service. We do not insist on advocating on behalf of people, likewise with follow-up. If we find that one of our callers is vulnerable or hesitant, the specialist might offer follow-up where they will suggest that they call the caller back in either 3 days or next week, whatever works for the caller, and they call back to make sure that the referral was correct and that the caller did actually get the service they needed. It's a great opportunity for us to also provide that next level of service once the initial priority is met. The demographic information about the caller, their needs, the referrals provided are then documented in our iCarol call report system, and that's used for reporting. Like I said, the service is fully bilingual, and we have multilingual capabilities with access to more than 150 languages through a real-time interpretation service. The phone service and online portal is available 24/7. Chat and text are available Monday through Friday, 7 a.m. to 9 p.m. And emails are answered usually right away, but certainly within 48 hours. The resource database that 211 maintains is Ontario's most comprehensive database of community resources. We have more than 60,000 records of community social health and related government services in Ontario. Because the 211 providers in Ontario are accredited, the standards for accreditation for the resource database must also be met, and that the minimum standards for that are accurate, up-to-date information and available online. The database is shareable, allowing the resource data to be leveraged by numerous partners on their website, their chatbots, or for research and planning. The database that is used by our 211 community service navigators, it's the same data and information, but has a different access point by our community navigators. And that allows them to then both search and provide the information based on eligibility, fees, areas served, language available, the documents that might be required when the person goes to apply, and the application process. Every record in the database is indexed using a North American taxonomy of terms, and this allows for easier retrieval and greater sharing across the province and the country. The reporting, this is our third and newer component of 211. It's where we share the aggregate resource and contact data with service providers and decision makers to help with planning when it comes to community investments and social policy. The data is categorized and reported out using a business intelligence platform, and you can see this in a public view on our website at 211ontario.ca. The metrics in the dashboard represent the types of service callers are looking for and the needs they are assessed as having. Callers' needs are tracked using the taxonomy. All data is aggregate and maintains confidentiality. The value of the social reporting, of course, increases the more 211 is used. So the more we have people coming to 211 to access information and referrals to the services in Ontario, the greater picture, the richer picture we will have on what the needs are of Ontarians across the province. Next up, we do have a few examples of 211 partnerships within the health sector. We've chosen 211 Central, based in Toronto, to give you an urban example, and 211 Central East, based in Collingwood, to provide a more rural example. And Carrie Moody is with us from 211 Central, and she'll provide an overview of their partnerships.
Thank you very much, Jackie. Hi, everyone. As Jackie mentioned, my name is Carrie. I'm the Director of Strategic Solutions here at Find Help 211 Central. 211 Central provides services for Toronto, Durham, Peel, and York regions. So that's a population of about 4 million people. We also provide after-hours support for the rest of Ontario and Nova Scotia. In total, we answer somewhere in the neighborhood of about 300,000 calls a year, in addition to chats, texts, and email inquiries from people looking for help on a variety of needs. Our greatest number of calls come from people looking to navigate health systems or for support related to the social determinants of health. So they might be looking for information about how to find a doctor or a walk-in clinic, or how to access support for a child with a developmental disability, or they might be looking for housing or food, all of which impacts people's quality of life, well-being, and sense of belonging. As Jackie mentioned earlier, our system develops resource data records for approximately 60,000 programs and services across Ontario. This data is vital to the work we do because it provides a foundation not only for our 211 service, but also to a number of specialty lines, including Central Access Withdrawal Management Service, Surrey Place Children's Services, Developmental Services Ontario, the Victim Support Line, and the Ontario Caregivers Helpline. Jackie also mentioned earlier that our data is shareable across jurisdictions, and this is really important to the work we do. Our data is leveraged across the province to inform decision-making, including things like a geomapping project that we have with the City of Toronto. This helps us understand where there are service gaps across the city, an app that enables the Toronto Police Services officers to quickly access programs for people in crisis, Chalmers Bot, which pulls together targeted information for people who are homeless or marginally housed. So that's things like food programs and shelter services, and employment and victim services for target populations. We also use the data to illuminate trends happening in the social service delivery system to improve investment and advance changes that will create a more accessible and easily navigated system. So 211 Central has a number of health programs to improve people's access to health systems. These programs create better access to service, they reduce duplication, and they create efficiencies for healthcare providers. So our aim here is really to connect people to services that care providers can spend, so that care providers can spend that time providing healthcare rather than connecting their patients to community services. Our Central Access Service was first conceptualized as a front door to withdrawal management services in the City of Toronto. The program was launched in December of 2006 and was hugely successful to enabling easier access for patients to detox services. And it reduced the amount of time that detox centers spent on inquiries related to bed availability. But what we realized was that there was an opportunity to improve access to these services by enabling the detox centers to update their records on their own, as opposed to our staff calling them each time someone called the line looking for a bed. So last year we developed the Withdrawal Management Bed Registry, which allows individual detox centers to update their availability in real time. So this creates live, up-to-the-minute information on bed availability in the system for more immediate support for people looking for detox services. In 2017, we launched our partnership with York Paramedics to reduce repeat visits to EMS for vulnerable patients. Paramedics were finding that they were going back to the same patients multiple times and felt that connections to community service agencies would reduce risk for vulnerable people, including seniors, people experiencing mental health issues, and those living in poverty. EMS providers didn't have the capacity themselves to work with patients to develop these connections, but they really wanted to ensure that there was follow-up. So the solution was to partner with 211 to provide follow-up and support the connection process. This could include anything from a warm transfer to advocacy on behalf of the patient if that's necessary. And our social prescribing community navigation project with the University Health Network will be a really similar project to that. It's based on the York Paramedics model, but that's evolving and could look slightly different as we move forward with that project. In some cases, our role moves beyond intake, follow-up, and referral to improve the ability of patients to access services for themselves and to better understand the health system. The Toronto Coaching and Health Project is a partnership we're working on with the South Riverdale Community Health Centre. And the purpose of that project is to coach people to be better able to navigate health services for themselves and to improve people's access to health and health-related services by implementing peer support, health coaching, as well as service navigation options. This is a really new initiative, and we don't have reporting on this right now, but the vision is really to ensure that people have the skills to navigate services on their own, as well as some support for more complex situations. One of the projects that we're really excited about is a relatively new partnership with the Eastern York Region, North Durham OHT, and we're really happy to have Michael Cole and Parissa Marifar here to speak with us today about the work this group is doing. Parissa is the Manager of Integration and Planning for the Eastern York Region and North Durham OHT, and Michael is the Chief Technology and Privacy Officer for Markham Stouffville Hospital. So I'll leave the project explanation to them and only say that we're really excited about the potential of this project and look forward to opportunities to scale and find connections to this work with other Ontario health teams. Thanks, Michael.
Hi, good morning, everyone. It's nice to meet the number of you, albeit virtually. On our first slide here, we just wanted to share an image of the Eastern York Region, North Durham catchment. For those who aren't familiar, quite an affluent community, yet in areas that are deemed quite heavily populated and or rural. I think it's a community that's also made up of over 60% visible minority and identifying English as a second language. Tying that in with what some of Carrie spoke to around the social determinants to provide some context for how not only our patients but provider want to receive and offer services. So our priority population for year one, well, the Ontario Health Team is actually focused on dementia, mental health, and addictions. We're actually focused not just on the patient, but on the clients, the families, and the caregivers. The data that we pulled to select these priority populations was based on the hospital's emergency department usage, feedback from family physicians and primary care providers, wait lists and a complexity of clients across community partners. But again, especially in the Ontario Health Teams and how we've positioned ourselves, actually working with partners in 211 and other similar where it's not hospital driven.
In order for us to start our focusing on our priority year one initiatives, we actually launched a very comprehensive survey back in summer. Given our population, we had the survey not only in English, but in Tamil, traditional Chinese, and French. And we actually went out and not only asked people that using the health system, but we went beyond and we attended ESL classes, we went to faith-based organizations, just to make sure that we are getting the voice of the residents that we will be serving. And what we heard consistent across all the population and residents was that the access and navigation is an area that everyone felt they needed support. We went on and we have done multiple co-design sessions where we got over 650 people come together, providers, physicians, frontline staff, board members, patients, clients, individuals seeking care, the family, and we heard again loud and clear what they wanted to see in the system and the change. And that's how we started our first initiative, really focusing on access and navigation. And when talking about access and navigation, this is a very aspirational initiative, recognizing this is a foundational work that will be supporting our OHT through our maturity. So we are looking to see how we can compile the existing assets and analyze the assets to figure out where are the gaps in the system. We are also looking at best practices and in order to figure out what is the recommended coordinated access and navigation model and match system resources to needs. And recognizing this is probably a work that all the other OHTs are engaged in, we are really happy and looking forward to collaboration opportunities. So if your OHTs, this is an area that whether you're working on or interested, please feel free to reach out and we'll be more than happy to connect and make sure that we are sharing the lessons learned. And where we saw the opportunity to work with 211 was really the focus that we wanted to build a centralized directory of both health and non-health related organizations and services that's currently available. And we went beyond and recognizing that there are multiple players in this field. So currently we are collaborating with 211, Healthline, Connects Ontario, the York region and Durham region to really validate the information and resources that are currently available. We also want to figure out what is the current intake, screening, and navigation processes in place across all these different organizations, as well as the OHT partners. I'm sure you all, when you have done your pre-assessment, recognize there are so many navigators in the system, but they're working very differently from each other. And unfortunately, sometimes there is inequity on the way the services are provided. And ultimately, what we are looking for is to bring it all back. And don't forget the voice of the patients and clients, and really co-design a centralized access and navigation, and bring that back as an advocacy to the government to figure out what is the model that can work for 2 regions. So as Michael alluded to, the fact that we are across 2 regions gives us a lot of challenges, but at the same time opportunities, and figure out if we can have a centralized access and navigation that works for 2 regions. Potentially that will be across multiple regions and provincial. So again, we are looking to see if we can build more partnership on this work.
I think as Parissa speaks to building more partnerships, a strong partnership that's spoken about not only here, but in a number of collaborative discussion with 17 of the other Ontario health teams from a digital perspective. We see a real opportunity from both a physical and a virtual navigator perspective, partnering with 211. And if others around the table would like to discuss that in the future or see opportunities to collaborate, please don't hesitate to reach out.
Thank you very much, Michael and Parissa. That was very informative. And are there any questions from any of the attendees at this point? If there are, please put it into the chat. Like I said, there will be an opportunity to ask questions at the end of the webinar. And we will also be sending out a recording and answering questions at that time. The chat can be found if you hover near the bottom of your screen. Yes, you will be getting a copy of the slide deck. And sorry, the question was, will we be getting a copy of the slide deck? Yes, we will be sending a recording of the webinar with a copy of the slide deck. Not seeing any other questions, I would now like to move on to Fiona Proctor. Fiona is coming to us from 211 Central East. And Fiona, can you hear me? And
I can.
Wonderful. Thanks, Fiona, for joining us, and take it away.
Thanks, Jackie. Hello, everyone, and thank you for taking the time to participate in this webinar. My name is Fiona Proctor, and I'm a registered nurse and manager of health and community impact with Community Connection 211 Central East. As you can see, we are the green section popped out and work with 10 counties and 2 districts. We have been working for a number of years with healthcare providers from a number of different backgrounds. On this slide, you'll see that we are working with community paramedicine and have closed loop referrals with healthcare providers. I will explain a bit more about this program in the coming slides. We are also working with some hospitals and a mental health response unit to complete closed loop referrals. On the technology side, this week we are testing a pilot program with the paramedics where we will start a 2-way stream of communication between paramedics and our community navigators to support people's social determinants of health. We are also in the midst of developing a platform that will enable us to complete the closed loop referral process efficiently and with bidirectional data sharing that is HL7 compliant. We are deeply involved with the development of the Ontario Health Team work happening in our region and have formal partners with 2 of those Ontario Health Teams. We will be hearing more from my partner at the Couchiching Ontario Health Team, Dr. McIntosh, shortly. The Simcoe County Paramedic Service has been working with us since 2015. They have completed a study indicating that when the sole referral from a community paramedic was to 211 Central East, our intervention with the patient has reduced repeat 911 calls by 28%. So let's get into what a closed loop referral looks like. While this slide is similar to the one presented earlier, it explains the enhanced interactions that set the closed loop referral process apart from a regular phone call to 211. We believe that the magic of our closed loop referrals happens at the following points. When you send us a referral with consent from your patient, we initiate an outbound call. As we all know, the chances of someone picking up the phone and dialing 211 on their own volition is low, depending on what's going on in their life. We phone them. While we're on the phone, we complete poverty screening and have a 3-minute empowerment conversation. I'll explain a bit more about the 3-minute empowerment conversation on the following slide. We are able to share the resources both with the patient and their carer if they so choose. And last but not least, we are able to send back an outcome report to you, the healthcare provider, that outlines our interactions, which resources were shared, and if the patient agreed to a follow-up call, we can report on whether that referral worked for them or not. So to summarize, the magic happens with us doing an outbound call, poverty screening and 3-minute empowerment conversation, and then sending the outcome report back to you. I can imagine that as you interact with many people in many different circumstances in your work, that people may or may not be ready, for a variety of reasons, to make changes within their lives. At Community Connection Central East 211, our community navigators are trained to have 3-minute empowerment conversations. After completing a fulsome assessment with the patient, we learn what items the patient is most interested in pursuing immediately. Should the patient be in the pre-contemplation denial phase or the contemplation ambivalence phase, our community resource specialists or community navigators would ask the question, how would it help you if you decided to? By providing an opportunity for patients to reflect on what and how their life could be different, we can potentially move them along the stages of change and towards additional supports that may enable them to remain in their homes. As a side note, we adopted this after a suggestion was provided to us while working with the Couchiching Family Health team. It takes a team to make the dream work. We created outcome reports designed to provide information that primary care providers and their teams want to know, and had them review and provide feedback to ensure ease of use and clarity. Our outcome reports do 3 key things. We let you know the outcome of your referral. We report on the patient's stage of change, which can be used to plant the seed and potentially explain why or why not your patient has or hasn't reached out for the resources they have access to. And lastly, when your patient returns, you can use the list of resources provided to reference if they need additional encouragement to move along the stages of change so that they are ready to take action and access the services that they would benefit from. We are also able to take the aggregate data from your team's referrals and give a really clear snapshot of the top needs, the demographics, whether all of the needs are being met or not, and how prevalent those needs are. This data can be used to inform programming, connections, and additional resources required to support your patients either internally or within the community. On that note, I'm going to pass this over to my colleague, Dr. Kim McIntosh. I've had the great pleasure of working with her over the past year and also had the opportunity to actually speak with one of her patients who spontaneously started singing her praises. Dr. McIntosh has a well-rounded approach to clinical practice and is an incredible positive influence and visionary as the clinical lead for the Couchiching Ontario Health Team.
Good morning. Can everyone hear me okay? So I'm a family physician in Orillia, and thank you so much, Fiona, for that overwhelming intro. Excuse me. So yes, I'm a family physician and I have a community practice. I also work at Orillia Sodros Memorial Hospital. I am a board member of the Couchiching Family Health Team and have the great pleasure of being the clinical lead for our Couchiching Ontario Health Team. So I'm going to give a bit of background. I attended a chronic disease prevention and management group seminar presented by the Simcoe Muskoka District Health Unit back in the fall of 2018, learned about poverty screening and thought, oh my goodness, how important would it be for me to bring that back to my practice? Because 50% of any human being's well-being is related to the social determinants of health. As a family physician, I can provide 25% of their care provision in terms of their overall well-being, but most folks struggle with, for those folks who are unwell, struggle with issues like poverty, and food insecurity and inadequate shelter. So learning that at that seminar, I thought I should do some poverty screening. But the last thing you want to do as a clinician is ask a question for which there is no answer or support. And 211 came into my awareness, and I was able to connect with Fiona and Dr. Harry O'Halloran, who had already implemented a 211 referral form in the EMR, electronic medical record, in Collingwood. And with that, in our EMR, I was able to launch a poverty screening tool project of 7 weeks duration in my practice with my colleagues. 646 patients were screened. 34% responded positively to the question, do you have trouble making ends meet? We were able to use our Ocean tablets, our screensavers in our rooms to promote 211, and then with patient consent, make a referral from our EMR to 211 with that closed loop follow-up and review and data analysis that Fiona mentioned, which was tremendously helpful. That screening pilot project Fiona and I presented on February 21st, 2019, so to our Social Determinants of Health Working Group, which informs our then Couchiching subregion, now Couchiching Ontario Health Team planning table. The data and the ability to follow up and the direct patient engagement, the accessibility for me and for my patients and their feedback is so tremendously important. We all can appreciate on the line, I'm sure, the paucity of system navigation and how that care integration is often lacking when we really want to help folks access care, particularly those most vulnerable. I also discovered you can order 211 posters free online. That's amazing. Big piles come. I walked them around our hospital and put them up everywhere. So 211 awareness has certainly been a project because of the capacity and the ability of a real person answering a phone to navigate for folks. So our current projects are a poverty screening tool uptake, our mental health group with our Couchiching Family Health Team are anticipating poverty screening tool implementation. I anticipate a primary care rollout. That is on the books. Our second major initiative with 211 is with Aurelius Soldiers Memorial Hospital and our quality improvement team, asking the question, did you get enough information when you got home from hospital? And transitions we know are tricky, and we want to facilitate safe transitions home from hospital. 211 is working with our quality improvement working group to look at how can that question be answered with a referral to 211 and then a protocol with Aurelius Soldiers Memorial Hospital in particular and our local resources being on the end of that conversation for patients who respond, no, I actually didn't get enough information and I need help in this regard. Our third current activity is with our Couchiching Ontario Health Team. Our planning table has received a presentation from 211, and there's so much education and dissemination of information that's required up front. We anticipate integrating 211 into our first year population of frail elderly, in particular around care integration, and having a Couchiching specific one number to call would be the vision. And those discussions are ongoing with our multiple partners. So it's been an absolute pleasure to work with Fiona and Pam Hillier with the Central East 211 group, and the ability and flexibility and data analysis and closed loop contact that really ensures we're not just referring folks to avoid has really, to me, made this such an important tool in how Ontario health teams address what really matters to folks and what makes up, again, 50% of their well-being, those social determinants. So any questions I'm happy to answer.
Thank you, Dr. McIntosh. It's Karen Milligan, and I just want to say thanks so much for joining, and from everything we've heard from Fiona and Pam, you've been an amazing leader in that area and certainly a great supporter of 211. So we certainly appreciate you being here today. If we can maybe scroll along to the next slide, and Dr. McIntosh will be with us and we'll get to a question and answer period very shortly. I just want to wrap up the information portion by talking about a few of the different ways that we partner even beyond the OHT partnerships that you've heard about today. So Many of you, we've described the core capacity of 211 in terms of its contact center operations, that rich resource data, as well as the needs and unmet needs data that can be shared with communities. So 211 acts as a front door with several partnerships in Ontario, helping to answer the Ontario Caregiver Helpline that's brand new. The Good to Talk service, which is a post-secondary mental health helpline in Ontario. 211 answers the first call to that helpline and then works with Kids Help Phone, Connects Ontario, and the Ontario Centre of Excellence for Child and Youth Mental Health to ensure that people either get counseling or detailed information and referral for mental health and addiction services, both on campus and off campus. So it's a great partnership with 211 playing that front end role. The other one that I'll mention really quickly, and I think Jackie alluded to it earlier, is a growing partnership we have right now with Ample Labs. And for those of you not familiar, they've created a chat bot for those living in homelessness or at risk of homelessness in the Toronto area. And it's currently expanding. It has expanded into Barrie, is expanding into Niagara, and they're in conversations in other communities as well to bring that chatbot to other communities. And of course, that is fueled by the resource data that's collected in the 211 system. The other nice thing about that chatbot is that if you reach a certain point in the transaction where the computer doesn't have any more answers, it will direct people to either call the 211 number or to connect with us via chat during those hours that Jackie specified. You see another bunch of partnerships reflected here, and there's certainly more information about many of these on our provincial website, the 211ontario.ca. So I encourage you to learn more, explore more, and we're happy to share any additional information if people are keen to explore further in their own community. So let's move ahead then, and we certainly had some general questions that were sent to us both in advance of the session as well as I think over the course of the call today. So maybe we'll just open it up, and Jackie, can you maybe throw out the first question that you...
I sure can, Karen. This first question says, can 211 hold and analyze client information such as income level, ethnicity, food insecurity, etc.? Did you want to take that one on, Karen?
I certainly can, but I was actually thinking that Fiona could perhaps field this one just as it relates to some of the work that she described with the systems they're putting in place.
So Jackie, can you read that question one more time for me, please?
Sure can. Can 211 hold and analyze client information such as income level, ethnicity, food insecurity, etc.?
Okay, so the short answer is yes. The more complicated answer is yes and no. We can absolutely delve into the so within the closed loop referral system that we operate in Central East, we have the capability of getting down to the nitty gritty of, what were the top needs dependent on housing, food insecurity. We don't gather down to the income level at this point in time, but could potentially explore that. We can get into the demographics if they are asked. We are also open to exploring that. And then we also can get into the, and I think Dr. McIntosh could even mention too, I mean, we can gather all that aggregate data and report back in a really quite fulsome way. What makes it so unique is that we are completely nimble as to the information that you are looking for, and if we gather it, we can put it together.
Great.
Thanks, Fiona. I'd also like to add to that in our data collection of when the caller comes to us, we only collect demographic data that would further assist the caller in accessing services. So if a service means that they must be on one of our social income programs, we might ask that question. And so our community navigation specialists are very sensitive not to ask a barrage of questions that aren't necessarily pertinent to the caller's needs. That said, it doesn't mean that we can't do snapshots in time of those sorts of questions, and we have, snapshots as to whether they are new Canadians or whatever the need might be. And we also, when a person self-identifies as having a particular income, or if they're a person with a particular disability, we do capture that, but it is only when it's self-identified. We don't ask those questions specifically unless it will further the investigation of the need for the client. Sorry, Karen, did you have anything else to add to that?
No, Jackie, thank you for covering that, and hopefully that answers the question. But if we haven't properly answered it, feel free to send an email post webinar, and we can clarify.
Certainly. The next question is, pleased to hear that you're looking at complementing different centralized systems. Is there an opportunity to link telehealth that triages health conditions with platforms like 211?
Thanks, Jackie. That's an excellent question, and certainly there are lots of linkages between different health partners, both on the data side as well as on the phone side. And so in terms of telehealth, there's an interesting set of relationships south of the 211s and CDC, for example, around their pandemic planning. So they've set up a program that they call Flu on Call. And essentially what happens is that 211 plays a front-end triage role, scanning for whether or not the caller has actually got a health need. And if so, they quickly flow those calls to a health professional. In this case, I believe it's a public health nurse who does further clinical assessment of whatever the issue is. But in probably 25% or more of the cases, it's just information that's needed and or direction to a local health center or urgent care clinic. So in some cases, the person is looking for some general information or advice, and certainly 211 playing that triage role at the front end is a great way to take the pressure off of the health professionals who are answering, in some cases, some inappropriate calls. That is an example that is living and breathing in the US. We have had several conversations with the people at telehealth over the years, and there's certainly opportunity for that to happen as well, whether it's just through a detailed call protocol that says in these cases, that telehealth would direct somebody to us, or in our case, in what scenarios would we either transfer that call or recommend that person call telehealth. So hopefully that answers the question.
Thanks, Karen. The next question, can you speak a bit about how local resources are identified, vetted, and kept up to date?
Yeah, absolutely. And thanks, Jackie. So I think, there are those who can absolutely speak more eloquently to this than I can, but the standards that are in place through AIRS that Jackie described earlier say that at minimum a full record, there needs to be a full update of every record in our database once a year. But what happens in reality is that there's ongoing communication throughout the course of the year, especially with those agencies that know 211 and are working closely with 211. They are letting us know more often than not about changes before we get to those automated update requests. So much of the scanning for new programs, services, or any changes in the human services delivery landscape comes out of conversations both at a local level as well as at a provincial level with various networks. Our United Way partners are always quite key because they exist in many of these local communities and sit at a lot of those tables and network discussions. So they identify those things that are happening that are changing the services available in some way. And that gets brought back into the 211 system through a variety of means, but there are certainly automated update processes. There's a way for agencies or others to suggest an update or suggest a new listing from our website at 211ontario.ca. And again, there are some automated processes in place for those 60,000 records that already exist in our database to ask for updates on an ongoing basis from people in those organizations.
Thanks, Karen. You may have said this and I may have missed it, but I just want to make it known that we do have an inclusion and exclusion policy. And that's really just so that we keep within the parameters of services that do meet that are there for the community. So we're not, if you want purely business services, you've got your Chamber of Commerce. If you're looking for community-based government health and social services, you've got 211. And I think that's probably a way that we can also separate that. But that is our inclusion and exclusion policy, which we also have. The next question we have is, this is Lynn Davies, CEO of Koochiching OHT, and she would like to thank Kim speaking on the webinar, as would we. So thank you once again, Dr. McIntosh. But Lynn's question is 211 ready for an influx of calls, and will you have staff trained and available to handle an increase in business? That one, Karen.
So what I would say is that currently there's capacity for certainly more calls into 211. We have in recent times, as I mentioned earlier, taken on a number of specialty helplines, whether that's on behalf of the province. So for a period of time, 211 was involved in an information line related to the basic income pilot. And then after that, we were involved in delivering the provincial human trafficking helpline. We've also more recently, as I mentioned, been involved in answering the Ontario Caregiver Helpline. So the nice thing about 211 is that it has the capacity to expand quickly. We operate as an integrated contact center. So the 6 areas that Jackie described earlier in the presentation are actually connected through an integrated phone platform that allows for flowing calls across different regions, accounting for spikes in a particular area without having to have necessarily bums in seats in each of those areas. So we can quickly flow those calls across the province as needed to account for any significant spikes in volume. All to say, there is some capacity. We would certainly need to add to our capacity if there was overwhelming demand for 211 to play a role in navigation with all of the OHTs, for example. But we'll cross that bridge when we come to it. I think all to say the infrastructure, the training, the skill set, it's all there to be leveraged. And again, depending on the level of growth, we certainly have strong relationships both inside of the organization, but also with our partners. So we can explore expansion as it comes to us, but yes, there is a strong capacity within the 2-in-1 system currently, and certainly a nimbleness that allows us to take on new partnerships quickly and adapt to changing needs of our partners.
Thanks, Karen. We have a lot more questions here and 5 minutes left, so I will read out what questions I can until it's time to end the webinar, and then when we send out the PowerPoint, we will send out the remaining questions with answers. The next question I have here is, do you also include services that can be paid for privately? And the short answer to that is yes, we do. They still have to meet some criteria. So believe it or not, we do get calls on 211 asking for the phone number for Kentucky Fried Chicken. And we educate the person, we let them know that that's 411, or, you know, and some of them give us really great song and dance about how they nutritionally need Kentucky Fried Chicken. And, you know, so we often will give them the number. But that is not the information that we keep. If we're talking about a service that might adapt clothing so that somebody who has arthritic hands can easily adapt their clothing to take it, put it on and off, that we would keep, although it may be a business. But we do inform the caller that it is a business. They need to check and make sure the pricing, keeping in mind that many of our community services also have a cost incurred to the individual and may need a sliding scale. So sorry, that was a long-winded answer, but I hope answered your question. Mm-hmm. Another question we have here is, can 211 report back data to us, i.e. volume and types of requests from specific geographies? The quick answer to that is yes, we can. On our website at www.211ontario.ca, you will be able to find the public data reporting from the business intelligence platform, and you can narrow that down to various regions and even into municipalities. So that information is there, and it is available to you. If you are needing more in-depth information from our business intelligence platform, we may have it. We just may not be making that public or not see it necessarily what the general public would want. But we certainly can work with you to see how we can get that information to you. Another question we have is, can 211 integrate or talk with software such as CareDove and resource management and referral? What are the pros and cons of 211 versus these kinds of software solutions for referrals? Karen, I'm not sure whether you'd like to take that one on.
Sure.
Thank you.
Sure, and really quickly, because I know we're running out of time, I guess the first thing I would say is that actually 211 is not a software solution. I think one of the keys, and a couple of people have mentioned this already, is that 211 provides really mediated assistance in navigation for people who are not necessarily able or capable to do that themselves. And so we can provide that live assistance, whether it's by phone or chat or text or otherwise. That's really the primary asset or capacity that 211 brings. There are other software solutions out there, and certainly what fuels many of those is the rich resource data that is collected in the 211 system. So those 60,000 program and service records is in many cases what can fuel a fantastic software program. But all to say, yes, we do have the ability to integrate. We've created provincial APIs to connect into our resource data to a variety of applications. So I think we can absolutely explore that with folks who are interested in seeing how that integration might work or examples of it. But yeah, so that's all to say that, you know, again, great question. we really see 211's value as being that voice on the end of the line or at the end of a chat session that can help people with the navigation function.
Thanks, Karen. And that really does wrap up our time. It is 9 a.m. Thank you, everybody, for joining us this morning. Have a wonderful day out there. I hope you stay dry and warm. We will get this recording and the slide deck to you. Thank you very much to Michael Pariza and Dr. McIntosh for joining us from your locations. And have a nice day, everybody. Thank you.